Okay, let's move on to case 2. So this is a young lady, a patient of mine. She is a nurse. I'll give you a little background. She had a history of scoliosis with a rod, and she works very hard. She's a bright lady, and she had episodes of recurrent wheeze. And she worked in the dialysis unit where there's lots of chemicals, and she was finally diagnosed with occupational asthma. Now, Jaime talked about peak flow meters earlier. You start with peak flow meters for occupational asthma. You do at work and at home. And then you do methacholine both while working and then again at a time off work to actually make the firm diagnosis. It's a complicated diagnosis, and there's a lot of medical legal implications for this in terms of employment and workers' compensation and so on. But anyway, went through all this, and she actually had to change her job and work in a different setting, and that settled down her asthma. But things didn't settle from there, because then she was getting episodes of recurrent sinusitis, and I would do x-rays occasionally with these sinusitis, and lo and behold, there was a full-blown sinus full of fluid each time. And we did spirometry on her to see how much of this was related to her asthma. And she had a little bit of obstruction, a little bit of restriction, and she had about 10% reversibility. Remember at the beginning we said reversibility was at least 12% and preferably a little higher. So it was borderline. So she was seen, people get bounced around in the system. She ended up seeing a respirologist, not sent by me, sent by one of her other doctors. And he put her on inhaled steroids and a LABA combination because that reversibility to her, to the doctor, felt like it was asthma. But she did not get better, which of course is a pretty good marker that something might be amiss in terms of what's going on if she's not getting better with ICS LABA and she has asthma. Of course, the first step is to make sure that she's taking it and she's taking it correctly. So when we talk about the reasons for poor asthma control, you got to go through those basics. The first step, again, is making the diagnosis correctly. So again, in this lady, I don't think we've proved the diagnosis with her because her spirometry was not diagnostic 100%. It was suggestive. So is she taking her medication? I can tell you this lady was very adherent. She was very motivated to get better. Was she taking it correctly? Was she using the inhaler properly? And she was. Then we have to think, well, could there be something else that's going on to affecting her asthma if it's asthma? And this is a situation where you could have rhinitis or GERD that can worsen asthma. Of course, obesity causes phenotype changes in asthma, and psychological overlay can affect asthma as well. Again, if she has asthma, just going through it, if she has the asthma process, does she have a trigger that's not been addressed, like smoking and pets and house dust mite and so on? And then if we've chosen the right drugs, and Jaime's already alluded to earlier, stepping up asthma to a biologic in people with severe asthma. So this is an article that we wrote in 2008 that looked at these steps, and I think they still quite valid today. If we go on to the next slide, Jaime's going to talk about an IPCRG tool that we created as well along this line.
Yes, this was an initiative from the International Primary Care Respiratory Group, with which we developed actually a desktop helper, improving the care of adults with difficult to manage asthma. And it has been translated into many languages, so it's not only available in English. And this has a rather complicated algorithm. I'm not going through all the details, but it investigates different steps. So it has been actually simplified by the use of simples. And this is a very easy approach, this acronym that you can remember quite well. So you look about smoking, is the patient smoking? Is the inhaler technique correct? Is the patient doing it as it should be done? Is it actually doing it? And so about monitoring, and also about pharmacotherapy. Should you go up or down the treatment? Are the patient having the adequate treatment for the asthma step? How is it lifestyle? Is patient exposed to allergens? Is the patient exposed to fumes or smoking? What about education? Does the patient understand the condition? Does the patient understand what asthma means and what it has to be done? And also what kind of support, and mostly for children who have somebody to care for them, or even elderly, what kind of support they have, support in their job in terms of eviction, the support in their environment. So these are quite an interesting approach that people can have for difficult to manage asthma, before you just say, well, the patient is not controlled, let's go one step up on treatment or refer the patient. Maybe there's a lot you have to do.
Absolutely. So, this is a lovely tool that we created to sort of assist clinicians before having to refer everybody out. I think asthma is a primary care condition that can be treated by primary care practitioners before referring out for the most part. But this case really highlighted something else, and this highlighted that something that looks like asthma may not be asthma. and what might it be? And so moving on, just to show you about this case, and you can see that this young woman's X-rays and CT scans show, well, on the right you can see just the X-ray doesn't look very clean. It's just a little dirty there in that upper lobe. And if you look at the CT scan, you can see those little sacs. And those little sacs are little sacs of bronchi that we call our bronchiectatic sacs. If we look at the next slide, it looks a little bit bigger, and you can see they're larger sacs there. That's not normal. Those are little sacs that contain fluid and often infection. So that's called bronchiectasis. So now we have a different situation. Remember our nurse who had this cough and wheeze, and we look at her CT of her sinuses, and she's also got, and you can see there on the right, her left ethmoid and maxillary sinus is all filled up with fluid. She's got sinusitis. So she has bronchiectasis and sinusitis. So is this asthma anymore? Now we're rethinking this because it seems to have an infectious component and there's something else going on. Is there a structural component? So I think it's reasonable to consider in someone like this some more detailed investigations. CBC is useful for both a neutrophil count and an eosinophil count. The eosinophil count helps us decide on steroid treatment. We've talked about alpha-1 levels earlier. A protein immunolithophoresis for someone like this would be important because maybe this is someone who's got an immune deficiency and is therefore unable to prevent these infections and able to treat them and therefore leading to bad infections. I'll mention FeNO here overall, not for this case particularly, although I did use it in this case. FeNO, or fractionated cell nitric oxide, is a small handheld device now that's available in many parts of the world, where you breathe into it and it gives you a surrogate measurement of eosinophilic inflammation. It's very useful for assessing adherence, and it's very useful, as it's going to happen in this case I'm going to show you very shortly. So moving on to this case.
Alan, just on FeNO, just a question on FeNO.
Yeah.
Simple to use. I don't know how the cost compares to a spirometer in Canada, but I just wanted to know what would you say is the utility in primary care from your viewpoint? So
it is available. It's available in most countries on the world. There's a number of different companies now that make it as well, which is giving us some choice, which is great.
Right.
It is easy to do in primary care. It's a simple airway maneuver. It's much less difficult to do of an airway maneuver than spirometry is.
Right.
Cost is an issue. Right now, it's not compensated in Canada as a procedure. So when I had my own machine, I basically had to pay for it myself, and I had to charge patients, which I couldn't be bothered. So it just basically cost me a lot of money, but it did give me some interesting information. What can it give you? Right. It can help validate your diagnosis. If you have someone who you think has asthma, and they're very symptomatic, and their FeNO is low, it probably isn't asthma if they haven't been treated. You can use it to assess adherence, because if they're taking their medication and their FeNO is still high, then either they're not adherent or they have severe asthma. And we haven't talked a lot about that, but it is a biomarker for one of our severe asthma therapies called dupilumab. It's a very excellent biomarker for that. And then lastly, it does help to monitor therapy. So if you give someone a treatment and their FeNO is falling, you know you're going in the right direction. If it's not falling, then again, why is that? And do they have some other kind of inflammatory condition, or again, are they non-adherent? So there's a few ways of using it. I'm going to come back to how I used it in this particular case as well. So let me just go on with this case, because she had bronchiectasis and sinusitis. She had a normal protein immunolithophoresis, so she did not have an immune deficiency. And she ended up having to have her sinuses drained. And while they were there, I asked the ENT doctor to do a biopsy of the actual sinuses as well, because I was suspecting what she had. And it did show ciliary akinesia. So ciliary akinesia is a very unusual situation where you don't have enough cilia. And when you don't have cilia, then you get developmental abnormalities. So what I didn't tell you about her, of course, I did tell you about her scoliosis, and I think maybe that's related to that, but she was also infertile. So we know that cilia is important in fertility and moving the eggs along the fallopian tube. And that fooled me because she had children. And then I realized actually that she actually had adopted her children, which I hadn't realized initially because I started looking after her when she was a little bit older. So that biopsy is there. Now, that's nothing we can really do about treating this. This becomes a physical thing. So what I did do for her was I weaned her off inhaled steroids very carefully, monitoring her FeNO the entire time. And she still had symptoms, and she was off her inhaled steroids and her FeNO was still low. I was quite comfortable at this point saying that she did not have asthma because her FeNO was negative and she still had symptoms. So by the way, she had bronchiectasis. So one of the things I do is work up for either tuberculosis or non-tuberculous mycobacteria. Obviously, depending where in the world you are, it's going to be different etiologies. In developing countries, again, tuberculosis, where you are, I know is a much bigger problem than it is in North America and in Europe. Those were negative for her. The treatment for her is to bronchodilate a little bit to help her clear her secretions, saline lavages for her nose, and airway clearance devices to help her get her mucus up. We'll move on to the next slide. I want to just describe airway clearance devices. There's a number of them around. The old ones are called the Flutter and the Acapella. The newer one by Trudell is called the Aerobica device, which I think is pretty fancy. But the concept on the bottom is, you can see that on the left is a plug of mucus. And what happens is, if we can get air in behind that plug of mucus, we can actually get it to be expelled. So this oscillating positive pressure device, where you breathe in through this machine and it flutters a breath through, causes this flutter wave to get in behind that mucus plug into the airway, even if it's a distended airway, and then it bounces back and helps you clear secretions. So with this oscillating positive pressure device, it's actually wonderful to help clear secretions. And all you basically have to do is you have to sit there at rest at tidal volume, just breathe in and out through the device for 15-20 minutes a couple times a day. And it's wonderfully effective for people who have a lot of mucus, like cystic fibrosis, bronchiectasis, and chronic bronchitic COPDers that have a lot of mucus as well. So in this lady, steroids was not the right answer. We talked about that being an issue before, using the right medicine for the right person. For her, it was a beta bronchodilator and airway clearance devices. So in summary, what this case really shows is that many things can look like asthma. If we make a firm diagnosis, we're less likely to get caught out with the wrong problem. Sean Aaron did a lovely article about this in terms of people that didn't have asthma but were called asthma in Canada, went through an entire process where they had spirometry, then methacholine, they reduced off their medications, and a good number of people did not have asthma at all. And you could predict who didn't have asthma based on the fact they didn't have spirometry done prior to the initiation of therapy. What's important, though, is a number of them had very severe diagnosis and things that, being not making the right diagnosis, had a risk of morbidity and mortality for them. So again, very simply, though, I understand we're going to trial treatment because that's what we do. We don't have these diagnostic tests available easily, and I understand that. But please, if you've given a treatment and it hasn't worked the way you expect it to work, make sure you follow up with your patients and say, wait a minute, this isn't working. Why? Is it something different?